Today, we are diving deep into a truly landmark study, one that fundamentally changed how we think about preventing strokes. It's called the European Carotid Surgery Trial, or ECST for short. And let me tell you, this wasn't just another research paper. Its findings became the very bedrock of modern clinical practice. To really get it, I want you to imagine something. Picture yourself as a doctor back in the 1980s. You have a patient with a seriously blocked carotid artery. The main highway for blood to the brain. Now, there's a surgery to clear that blockage, a carotid endarterectomy, but there's a huge catch, and it raises a really tough question. Because that cure, it was risky. In the ECST, the operation itself carried a 7% risk of causing a major stroke or even death within just 30 days. Think about that. That's about 1 in 14 patients. So doctors were faced with this incredible dilemma. When do you recommend a procedure that could kill or disable the very person you're trying to save? That's the puzzle this trial had to solve. And this wasn't just some academic debate. For the medical community, this was a genuine life-or-death question. The surgery was getting more and more common, but it was being done based more on theory and hope than on solid, hard evidence. The investigators themselves put it perfectly. They said they were in a state of clinical equipoise, which is a fancy way of saying they were genuinely, substantially uncertain about what the right thing to do was. So their goal wasn't to prove a theory they already had. It was to find a real, definitive answer. And to find an answer that big, you need a serious study. So they designed what was, for its time, the ultimate medical trial, a huge, prospective, multi-center, randomized, controlled trial. And the scale of this thing was just enormous. I mean, look at this timeline. The study spanned nearly 2 decades, from the very first patient enrolled in 1981 all the way to the final results being published in 1998. This wasn't a sprint. This was a true marathon of medical research. The way they did it was incredibly rigorous. Okay, step 1. They enrolled over 3,000 patients who had all had recent symptoms, like a mini stroke or a TIA. Step 2, they randomly assigned them, like a coin toss, to get either immediate surgery or just the best medical therapy they had at the time. And then step 3, and this is crucial, they followed every single one of those patients for an average of 6 years to see what happened. Now, in a study this big, you have to decide what your main measure of success is. For SEST, that was what we call the primary outcome. And they defined it very clearly, the first occurrence of either a major stroke or death from any cause at all. That was the yardstick they used to judge whether the surgery actually worked. So, after all those years, all that meticulous work, the data started to tell a story. And it was a story that turned out to be complex, sure, but absolutely decisive. You see, the trial's big finding wasn't a simple thumbs up or thumbs down on the surgery. It was way more nuanced than that. The researchers discovered that whether the operation helped or hurt depended entirely on one critical factor, just how blocked the patient's artery was. Let's break it down. For patients with only mild blockage, we're talking less than 30% narrowing, the answer was crystal clear. Surgery was actually harmful. That upfront 7% risk of the operation was way worse than any potential long-term benefit. For them, medical therapy was absolutely the safer choice. Okay, what about the middle group, patients with moderate blockage? Well, here, the data showed no real difference between the two groups. The risks and the benefits basically canceled each other out, so no clear advantage to doing the surgery. But then we get to the patients with severe blockages, over 80%. And this is where the results were just dramatic. For these patients, surgery was a lifesaver. It nearly cut the 3-year risk of a major stroke or death in half, dropping it from over 26% down to just under 15%. For this group, that upfront surgical risk was absolutely positively worth taking. We can actually boil that incredible benefit down to a single, powerful number. It's what we call the number needed to treat. For these patients with severe blockage, you only had to perform surgery on 9 people to prevent 1 major stroke or death within 3 years. That's a huge impact. But the data had even more to tell us. It wasn't just about the percentage of blockage. The benefit was most pronounced in younger men. It was a bit less clear for women and the elderly. And a big reason for that was because in this particular study, women actually had a higher risk from the surgery itself. Now, here's a really crucial detail, especially for clinical practice. At the same time ECST was running, a similar big trial called NASCET was happening in North America.
They both came to similar conclusions, but, and this is a big but, they measured the artery blockages in different ways, and that could lead to a lot of confusion.
So the ECST method measured the narrowed part against what they estimated the original healthy artery width was. NASKIT, on the other hand, compared the narrow bit to a healthy section of the artery further upstream. The end result? For the exact same blockage, the ECST method always gives you a higher percentage.
So what's the practical takeaway? It's pretty simple, really. A blockage that ECST calls 80% is roughly the same as a blockage that NASET would call 70%. And knowing that is absolutely vital if you want to apply these trial results correctly in the real world.
So, after all that, what is the ultimate legacy of this incredible scientific effort? Well, it's a legacy that's written every single day in hospitals all around the world, saving lives by making sure the right patients get the right treatment at the right time.
To put it simply, the evidence from ESCT, combined with NASCT, became the foundation for all modern stroke prevention guidelines. These trials replaced uncertainty with evidence, and they replaced guesswork with precision medicine.
And you can see that legacy reflected directly in the guidelines we use today. Surgery is strongly recommended for severe stenosis, that's over the 80% ECST threshold. It's considered for some patients in that moderate range, and it's actively avoided for mild blockages, all to prevent doing unnecessary harm.
The ESCSD gave us definitive answers for its time, but of course, medicine never stands still. The medications we have today are so much better, and surgical risks are much lower than they were back in the 80s and 90s. And that leaves us with a really essential question for the future of stroke care.